Recording in progress.
Good evening and welcome to the August BOMSS Journal Club. I'm really delighted that we've got our previous BOMSS president, Professor Kerrigan, and the team from Phoenix Healthcare with us this month. Thank you very much for joining us. We've got a couple of really fantastic presentations and topics to come with plenty of discussion. So I hope you're looking forward to it. And just to introduce our co-chair tonight, we have Amy Ride. Thank you for joining us. And our sponsors to Ethicon for sponsoring this evening. Now, just a recap of our BOMSS programme. The next session that we've got is on the 24th of August, which is the educational webinar, which is being presented by Iskandar Idris on the mechanism of diabetes remission after bariatric surgery. So we hope to see you then with us too. And for those who are new to the Journal Club, tonight we're going to have two presentations, both lasting about 14 minutes with about 6 minutes of discussion afterwards. So please, while the presenters are delivering their talks, please give us your questions, comments and thoughts into the Q&A box, and then we'll be able to bring them through afterwards. So without further ado, I'm going to hand over to Professor Kerrigan to introduce his team. Thank you very much.
Yeah, so just let's say thanks, Roxana, for giving us the opportunity to host the Journal Club this week. It's a great privilege. We've got two of our team from Phoenix Health based in Chester who are presenting today. We've got Sam Dixon presenting first, who's one of our 3 specialist bariatric nurses, followed by Pete Coe, who's one of the 2 current bariatric fellows we have. And congratulations to Pete, if you haven't heard, for his appointment to a consultant post at St James's in Leeds. So he'll be leaving us sadly in November. So watch out for the advert that went around recently for Pete's replacement post with us. It's a busy unit, so we've got a great team of people working with us, psychologists, nurses, dietitians, and obviously surgeons. We do about 600 cases a year. I mean, fortunately not too badly affected by the recovery from COVID, so lots of work going on.
Brilliant. Okay, evening everyone, I'm Pete Coe. I'm one of the post-CCT fellows in bariatric surgery at Phoenix. And thank you all for joining this evening. So I'm going to talk about this article published in JAMA fairly recently that explores the association of bariatric surgery with cancer risk, as well as mortality in adults with obesity. And I guess the question I always have when I see one of these articles is bariatric surgery now a viable cancer risk prevention strategy? So obesity, just a bit of background, obesity and cancer risk is now well established, who has associated 13 different cancers with obesity. And bariatric surgery really offers an ideal scenario in which to test the question, is this a modifiable risk factor for the development of cancer? Some of you may remember the fairly controversial set of advertisements and run by Cancer Research UK about 5 to 10 years ago that highlighted this risk, but without it being a modifiable risk factor, it really runs empty for many people that already have established obesity. So the article I'm going to discuss today, it's been published in JAMA, which has a huge impact factor. It's very contemporary. It was published just a couple of months ago. It's important to note that it's from a US healthcare system electronic patient record, one based out of Cleveland Clinic. I think that does somewhat limit its applicability. The authors are stellar publishers in the field of bariatric and metabolic surgery. And it's a matched cohort study. So the patients in this study were 5,000 patients that underwent bariatric surgery, either a Roux-en-Y or a sleeve gastrectomy. And they were compared to 25,000 matched non-surgical controls. The primary outcome of this study was time to incident obesity-associated cancer, and that was those 13 World Health Organization associated obesity-associated cancers. To analyze the authors used time to event analysis, so a multivariable Cox regression analysis. We share some of the detail about how they underwent matching their cohorts, because I think it's probably important to how valid the study is at the end. They took over 670,000 patients in their database with a BMI of over 35. From that, they found over 8,000 patients who'd had bariatric surgery and excluded a lot of the confounders for the development of cancer. So patients who already had a history of an organ transplant, HIV, who already had things like peptic ulcer disease or had prior history of cancer. They then looked at their non-surgical control group, of which there were over 600,000 patients, and applied the same exclusion criteria as well. Ultimately, they ended up with 5,000 patients who'd undergone bariatric surgery and matched those on a 1:5 basis to give 25,000 patients who were the non-surgical match controls. As I've mentioned, they plan to use multivariable Cox regression using time to event data. And they also performed a number of sensitivity analyses and subgroup analyses to test their hypothesis. In addition to time to obesity associated cancer, they also looked at the incidence of all types of malignancy. And then if a patient did develop cancer, what was the mortality from that cancer? Unsurprisingly, after they matched patients, the baseline characteristics were broadly the same between the two groups. It's important, however, when we look at the baseline characteristics, that we look at the average age of these patients, so they were just 46, and the fact that the vast majority, so over 75% of patients, were female. These patients all had a BMI of over 35, and in fact, the median BMI was 45. And they were also well matched for a number of different comorbidities, including myocardial infarction, diabetes, and a global assessment of that, which is the Charleston Comorbidity Index. When you look carefully at the characteristics of the different groups, however, there is one area that does stand out. So patients who underwent bariatric surgery had significantly higher rates of cancer screening prior to their procedure, as well as after their procedure. And I think this might show an important difference in the health-seeking behaviour of the two groups that the study explored. So just moving on to the results, I think one of the first questions is, well, did the intervention achieve what it intended to do? Did it cause weight loss? And they nicely show that up to out to 10 years, there was an almost just over 20% loss of weight following bariatric surgery, which wasn't shared by the non-surgical control group. When looking at their primary outcome, the authors found that there was a significant reduction in cancer, obesity-associated cancers at up to 10 years. This was about a 30% risk reduction. So in the non-surgical control group, there was an approximately 5% risk of cancer at this time point, whereas in the patients undergoing bariatric surgery, this risk was more like 3. What's key to note here is that the numbers at risk of patients as you extend through the study became smaller, and actually the median follow-up time was 6 years, which I think is an important sort of sub-point. The authors performed a subgroup analysis, so to extend this association across different subgroups. And they actually found that this association was pretty consistent across all subgroups. However, where the patient populations were smaller, such as in male patients and in races other than black or white, this association was much weaker and the confidence intervals greater. However, I do think here they showed some consistency in their outcome. They explored a number of secondary outcomes, the first of which was the total number of cancers picked up. And again, they found that in the non-surgical group, the rate of cancers was greater than the bariatric surgery group. And this rate was greater than can be attributed just to the obesity-related cancers. They also found that for patients who developed cancer, the risk of mortality from that cancer was much lower in patients that had undergone bariatric surgery compared to those that hadn't. And that risk was 50% lower. If you look in the detail of some of their results, however, what you can see is the actual risk reductions are quite small. So if I can draw your attention in the middle here to endometrial cancer. So the rate per 1,000 person years for patients who underwent surgery was about 0.5, and patients who hadn't undergone surgery was just 1.3. So while this is a large relative risk reduction, actually the number of cancers per lifetime of a person is really quite small. So this is the rate per 1,000 years. If you look at some of the other non-hormone driven cancers, and I've just highlighted two of them here, gastric and esophageal cancer, there was no association found at all. A really important outcome of this study, and I think one that's novel, was that they found that there was a dose-dependent effect of weight loss on cancer risk. So this graph shows the different the weight loss of patients split into quartiles. So the patients with least weight loss on the top and the most weight loss on the bottom. What it shows is that patients who achieved under 25% body weight loss had a similar cancer risk to patients who didn't undergo surgery. The reduction in risk, in cancer risk, was greatest for those with the greatest weight loss. And this really, in my opinion, supports the biological plausibility of bariatric surgery as a cancer risk reduction strategy. So what do I think of this study? Well, I think it's certainly of clinical interest. It's highly relevant on a population level. Obesity rates continue to rise, and potentially of interest to patients undergoing bariatric surgery as well. The relative risk reductions appear high, although I'd argue that the actual risk reductions are far more modest. I think the methodology is fairly sound. There are clearly defined inclusion and exclusion criteria and clearly defined primary and secondary outcomes. There's been some thoughtful matching of these groups. However, when you look at some of the tools used to assess observational studies, I think this study is actually at serious risk of bias, both selection bias, so there is and bias by confounding. So I think there are likely to be a number of unmeasured confounders, as well as patient selection and patient choice for bariatric surgery that will interfere and affect the outcome results. I think that this can particularly be demonstrated by the difference in screening rates between the two groups. That being said, if you take at face value the methodology, I think the results are reliable. There is an extremely large number of patients and very good length follow-up. I think we've got to be very careful about who we apply any of these results to. It is really only applicable to women and patients who are a younger age. So overall, I think this is quite a good quality study. It re-demonstrates that the associations between bariatric surgery and cancer risk reduction are greatest for those hormone-related cancers, so breast and endometrial cancer. I think, as I've said before, the evidence of a dose-dependent response between weight loss and cancer risk reduction really supports biological plausibility. but it also supports the variable findings in the literature of the association between bariatric surgery and non-hormone obesity-related cancers. And this may reflect the difference in the biological driver of these obesity cancers, as well as the age and sex of the patients in these studies. I think in the future, the indications for bariatric surgery in the context of cancer risk management will require far more refining of the at-risk population, the type of surgery that may be applicable to them, and the patient comorbidity profiles that are suitable for this as a strategy. And to my mind, at this stage, cancer risk reduction should not play a role in the clinical decision-making when considering the broader benefits of bariatric surgery. So thank you, everyone.
Thank you very much, Peter. That was really, really interesting. I think that's a really valuable paper, actually. I think it gives us quite a lot of information. I was curious to know, obviously you found quite a few limitations to the study, but do you think that we should be talking to patients pre-surgery about the risk of cancer related to obesity and the potential for bariatric surgery to reduce that risk?
So I think my opinion on this is very much at this stage, no. The papers, so there's a number of papers that have now been published on this topic, and this latest one really reiterates a number of the associations previously shown, but they all suffer from the limit of mostly being in a certain age group and a certain and mostly female. And this may not reflect all the patients that are in front of us. Additionally, if you look at the high risk cancers for females of this age group, so endometrial and breast, actually the incidence across the study is quite small. And so while the relative risk reduction might appear large, the absolute risk reduction is really very small. I've not done any numbers needed to treat analyses on these data, but you could do. And I suspect what it would show is that you are operating on a huge number of patients just to avoid one cancer.
Yeah, it's interesting because it's such a big study, isn't it? They've spent so long collecting all the data, but actually when we think about what we can do with it, we're quite limited at this stage, aren't we?
Yeah, absolutely.
Yeah. Would you think it would be any role for sort of in the future discussing it when we're sort of talking about commissioning services or you know, anything along that line? So
I think yeah, I think that's really interesting. I mean, probably in the broader context of obesity services, definitely. Perhaps not so much in bariatric surgery services. Yeah. I think it's too early for that. I think the biological mechanisms are too poorly understood. And there may be, you know, so things like GLP-1 are also linked to obesity-driven cancers. And so there's probably equal number of questions about whether the use of medications that influence that pathway could influence this. And so perhaps, you know, I think there's still too many unanswered questions, really.
Yeah, thank you.
Thank you. Prof, did you want to comment?
Yeah, Pete, the thing that struck me about this study was the young median age of both groups. I mean, 46 years old for the bariatric surgery and for the control group. 46 is quite young for a group of people to get cancer, although I do appreciate the fact that you had quite a lot of women's cancers that were producing the more positive results in this. So do you think that's a fair comment, that it's okay that they were so young and it validates the study because so many of the cancers were endometrial or breast cancers you might expect in a younger population? Or do you think actually this study underestimates the true benefit of the weight loss from bariatric surgery because actually they didn't look at patients who are old enough, who are in the high risk cancer group?
So I think you're absolutely spot on. What is needed is even longer follow-up and larger cohorts. You know, it's a sort of a bit of a cop-out answer, isn't it, to any research study? What we need is a better, longer, bigger study. But you're absolutely right. You know, the median age of pancreatic cancer development, for example, is in the 50s and early 60s. And it's the same with gastroesophageal cancers as well. And so if we look at risk reduction in these cancers, we wouldn't expect to see it in this patient group but we might expect to see it in an older patient group where bariatric surgery had occurred. That being said, it may be that removing that that stimulus, that obesity stimulus, later on in life, the removal of the stimulus may not result then in a reduction in cancer risk. So that's another of the biological questions that need to be answered and teased out from this.
Yeah, there's certainly lots of evidence that, obesity is a pro-inflammatory state, a pro-inflammatory condition, and we know that inflammation is one of the common underlying factors in cancer formation. So there is plenty of theoretical biological reasons to support why this should be beneficial. But yeah, interesting paper and great presentation. Thank you.
Yep. Thank you very much. And actually, just on that note, you also made a really interesting point that there's a higher rate of cancer screening in these patients and potentially linking that to their health-seeking behaviours. Is this something that you think was unique to the US healthcare system that they were looking at, or do we think it translates here? And then should we actually be screening our patients more for cancer?
Yeah, so I think in this paper in particular, the Cleveland Clinic is an internationally renowned health system, I guess, and it probably, I'm not quite sure whether it reflects the insurance of these patients, it reflects their own health-seeking behaviour, but it certainly shows, a difference at baseline between the two groups that probably limit how valid the results are, in my opinion. Mm-hmm. And then when you look at in the UK, certainly in the NHS, the patients are probably very different. And at 46, for so many patients to have undergone screening studies would be very unusual in the UK. So yeah, it definitely limits the applicability of that study to our practice here.
And thank you. Just another quick question from the audience. Sandra Johnson has asked, do you think more patients will present for surgery if they're aware of the risk of cancer due to obesity?
So that Cancer Research UK set of advertisements was really controversial at the time. A lot of people felt it was obesity shaming. I'm not sure whether it had any influence on how many people presented or sought bariatric surgery. I must say, it's not a common, cancer risk reduction isn't a common conversation we have in clinic, certainly in my opinion.
Thank you. Okay, that winds up the surgery paper. Thank you so much, Pete. That was fantastic. Prof, in the interest of time, should we move on to our second paper now?
Yes, please.
And I believe that we have Sam's slides.
Okay, good evening, everyone. Many thanks for the opportunity to present a paper of interest to me. I've chosen high-risk alcohol use and disordered eating behaviour before and 1 year after sleeve gastrectomy by Wong et al. From the Obesity Surgery Journal. Next slide. The Roux-en-Y gastric bypass has been linked to high-risk alcohol use following surgery, even amongst those patients without prior history of misuse. Because of this known risk, the sleeve gastrectomy is often the operation of choice if a patient has a history of alcohol excess or a history of alcohol use disorder. The authors have identified that few studies have explored the possible link of high-risk alcohol intake post-sleeve gastrectomy. Of the research explored, there is conflicting data. A large multi-institutional study performed by IBRAM showed an increase in alcohol use after sleeve gastrectomy, whereas a study performed by Colusi showed a decrease in alcohol use 1 year post-sleeve. They attributed this to the strict nutritional follow-up post-op. These studies did not examine whether prior disordered eating played a role in their findings. Next slide. Other studies have examined pre-surgery binge eating behaviours and have shown that it leads to an increase in substance use after other weight loss surgeries. Ghrelin, the hunger hormone, is altered following both the Roux-en-Y gastric bypass and the sleeve gastrectomy. It has been implicated to play a role in addiction. Next slide. The primary aim of this study was to categorise high-risk alcohol use and disordered eating in patients before and 1 year after sleeve gastrectomy. The authors fully acknowledge that this was preliminary data, potentially to better perform medical decision-making, risk stratification, post-operative management, and the surveillance of patients. Next slide. The inclusion criteria was as follows: a BMI of 40 or a BMI of 35 with a major obesity-related comorbidity. The planned procedure was the sleeve gastrectomy. The cohort of patients were from a single academic centre in Boston. Each participant underwent a 10-minute telephone interview at baseline and at 1 year follow-up. Next slide. 2 assessment tools were used, the first being the Audit-C, which was a modified version of the Alcohol Disorder Identification Test consumption. This assessed alcohol use and high-risk drinking at baseline and at 1 year follow-up by measuring frequency of drinking over the past year, the average amount of alcohol consumed when drinking, and binge drinking over the past year. The Audit-C scores ranged between 0 and 12. High-risk drinking was defined as a score greater to or equal to 4 in men and greater to or equal to 3 in women. Next slide. Food cravings and eating behaviours were assessed using the 3-factor eating questionnaire revised 18. The 18-item questionnaire identified cognitive restraint, uncontrolled eating, and emotional eating. It provides a scale 0 to 100. Next slide. The authors hypothesized that patients with a higher baseline score for disordered eating were more likely to report high-risk alcohol use after surgery. They also hypothesized that those patients who showed a greater improvement in disordered eating were more likely to develop high-risk alcohol use after surgery. Next slide. Of 198 eligible patients, 97 completed both questionnaires at baseline and at 1 year follow-up. 13 of the 97 patients had high-risk alcohol use at baseline and 84 patients did not. There was no statistical difference in baseline eating scores between high-risk alcohol users and non-high-risk drinkers. Of the 97 patients at follow-up, 22 were now high-risk drinkers compared to 13 at baseline. The authors considered the impact of COVID on alcohol use and discovered that 17.6% reported high-risk drinking pre-COVID versus 40.9% during COVID. Next slide. The 16 new high-risk drinkers also reported larger improvement in disordered eating at follow-up compared with the 68 non-high-risk drinkers. The improvement in cognitive restraint was statistically significant. A trend was revealed in uncontrolled and emotional eating improvement. Next slide. Of 13 with high-risk drinking at baseline, 6 persisted with high-risk drinking at follow-up. These 6 had a trend to greater eating disorder at baseline than the 7 patients who resolved their alcohol use. Next slide. 6 of the baseline high-risk drinkers reported greater improvement in eating behaviours at follow-up, compared with the 7 whose high-risk drinking resolved. Next slide. In conclusion, these studies' findings are: 1 in 5 patients reported new high-risk drinking at 1 year follow-up after sleeve gastrectomy. These patients reported worse eating behaviours at baseline and greater improvement in eating behaviour at follow-up. Half of patients reported a resolution in drinking excess at follow-up, but reported less improvement in eating behaviour at follow-up than those with persistent alcohol use. Next slide. To return to the hypothesis, the authors indeed suggest that those with higher baseline scores for disordered eating were more likely to report high-risk alcohol use after surgery. Those with greater improvement in disordered eating were more likely to develop high-risk alcohol use after surgery. Next slide. The discussion points are raised as follows. 13% undergoing sleeve gastrectomy reported high-risk drinking at baseline. This compares to 14% and 20% for Roux-en-Y gastric bypass and gastric band patients, respectively. 19% of patients developed new high-risk drinking at 1 year follow-up after sleeve gastrectomy. This compares to 7% and 9% for the Roux-en-Y gastric bypass and gastric band patients, respectively. It is possible that the timing of the COVID pandemic impacted this cohort of sleeve patients. It is well known that in general terms, alcohol sales trebled during the COVID pandemic. Next slide. However, the Abrams study identified 9.6% alcohol use disorder at baseline, decreasing to 8.5% at 1 year following sleeve gastrectomy. This increased to 14.4% at 2 years. The studies were not directly comparable due to the difference in definitions and thresholds of measurement. The authors of this paper were self-critical of the small sample size, subsequent subset analysis with even smaller numbers, and possible underreporting of undesirable behaviours. Next slide. Following sleeve gastrectomy, consistent with data from Roux-en-Y gastric bypass and gastric banding, as much as half of the patients with high-risk drinking at baseline reported a resolution of their alcohol use. Patients who exhibited greater disordered eating at baseline and reported larger improvement following sleeve gastrectomy appeared more likely to develop new high-risk alcohol use. There is a suggested paradoxical relationship between both baseline disordered eating and reduction in disordered eating behaviour, with the development of high-risk alcohol use following sleeve gastrectomy. The authors suggest that this lends weight to the addiction transfer model. Next slide. The message that I take from this paper is that we should perhaps be more circumspect about the sleeve being the default procedure of choice for patients who experience alcohol misuse, and that such patients should be afforded the same scrutiny and care as those undergoing Roux-en-Y gastric bypass. Many thanks.
Thank you so much, Sam. That was such an interesting presentation and actually some really stark figures. Can I just ask, I know this all focused in terms of alcohol, but in terms of the hypothesis that was put forward by the authors or your own thoughts, is it just alcohol or are there other addiction-seeking behaviours that seem to increase in this population?
Alcohol is generally the most common that's been investigated. I didn't explore substance abuse, but from anecdotal advice or anecdotal experience, there has been some, even in the codeine has been an issue with some patients as well.
Okay, and are there any, do you have any thoughts in terms of the mechanisms, or did the authors propose any? Because often, especially the link to eating disorders or eating behaviours and patterns makes us think, well, often can link to the gut hormones, but from your perspective, any ideas on the mechanism?
I think it highlights the importance of a multidisciplinary team approach in the assessment of patients. At Phoenix, we would have the dietitian assessment, psychology assessment, and the surgeon assessment. So thankfully, all those areas are covered. And then at our MDT, that is discussed. So I think that's really important in patient selection, but also choosing the procedure.
And do you have psychology in terms of post-operative follow-up as well? Or is this something that you would all pick up?
Yeah.
Okay. that's a significant benefit compared to many of the NHS systems.
Yeah.
Oh.
Yeah, so what I thought was really interesting about this paper was that the people who did the best at controlling their disordered eating and did really well and improved on that were the people who ended up turning to more alcohol. So I just wondered, did the authors, I guess because you haven't presented it, they didn't, but did they look at weight loss? So in other words, did people who corrected their disordered eating do better with weight loss because they'd addressed that problem and therefore perhaps felt a little bit more laid back about alcohol? Whereas those who were struggling a little bit still were being a bit stricter about everything, including alcohol. It's just a bizarre thing, is that someone who's actually made some really positive changes then goes and makes a really negative change, unless, as you say, it's support for this transference theory of addiction. But what are your thoughts on that?
They didn't explore weight loss at all, but I think it just puts more credence towards the transfer addiction model, the fact that they've replaced their disordered eating with alcohol use. It's seen as a coping mechanism.
Or perhaps, could it be, I don't know, I'm just thinking like perhaps, you know, if they're doing, as you're saying, they're doing so well in terms of their eating, in terms of socializing and lifestyle changes and quality of life and everything that comes with it, maybe there's a link in terms of increased socialization as well, and therefore that might come with alcohol and independence. Okay, Amy, did you have any thoughts?
Sorry, I was curious, do you think this is something we should be discussing, perhaps obliged to discuss as part of informed consent?
I think so, because of the risk, the significant risk after, and I think patients understanding they need to be educated in the potential problems post-operatively, but during the psychology assessment, that is explored, and certainly even in the dietitian assessment as well, they would look at coping skills in that, especially if there is emotional eating identified. And certainly in the ongoing reviews that the nurses and the dietitians would do, we explore alcohol intake, but also eating behaviours. And if we are concerned, thankfully, we have the luxury to seek support from the psychology team.
Yeah, I think it's a really important thing as well that we keep an eye on that side. People are aware that there is, you know, potentially an increased risk when they're going into surgery as part of their, you know, their decision-making process. It'll be interesting to know how that measures up across the country. It'd be interesting to know whether everybody's addressing it. And I don't know, I did wonder whether we ought to be thinking about a BOMSS resource for things like alcohol and other, you know, it could perhaps be something we think about in the future. Yeah.
It's a really interesting point, and I know Denise Radcliffe, who's obviously a psychologist, spoken at lots of BOMSS meetings, who works with us. Denise has really felt quite strongly about the published literature so far that, you know, if somebody really does have a bit of an alcohol problem beforehand, we ought not to do a ROM-Y because of the data that's out there. But this is actually quite interesting because it does challenge that, you know, suggesting that the sleeve isn't an awful lot better. And one of the arguments put forward was to do with alcohol absorption. And we know alcohol generally gets absorbed through the stomach, but does it get absorbed even more quickly if it's going straight into the small bowel with no pylorus to control emptying? Because the worry was always the effect of that alcohol on the liver. So if you're taking a certain amount of alcohol, if you're absorbing much more of it than normal, it's going to have a bigger hit on your liver, and therefore you might actually get sort of alcohol-related liver problems. But I think it's actually a worthwhile thing to go back and look at. I personally don't have that to the tip of my fingers about the difference in alcohol absorption post-ROM-Y compared to, say, something like a sleeve. It would be a good study to do if it hasn't been done.
Yeah, absolutely. That's some food for thought. If any of the members, and while we're just checking if the audience have got any questions, could any of you advise what is the best tool to use for those of us who don't have post-operative psychology support and are assessing people in the follow-up clinic? Does the audit C actually translate post-surgery, or are there other specific screening tools other than direct questioning that we should use to be able to pick this up?
I think nutritional blood monitoring is very important, because that can sometimes indicate if alcohol is an issue, and it sometimes can be a way of broaching the subject with the patient, because obviously it is a sensitive issue, because it's seen as an undesirable behaviour, and they can often be a bit embarrassed or feel judged. but it's a good way of surveillance and perhaps bringing up concerns and also educating the patient in the potential impact of alcohol, because a lot seem to think it's empty calories is the main concern rather than the potential harm to the liver.
Yeah, absolutely, absolutely. And just while we've got time, there's one question from the audience, from Sandra Johnson, who said, I think more input is needed regarding addiction with bariatric patients. We all have coping strategies, but if patients turn to food, they need another avenue. Maybe more funding or importance needs to be given regarding psychology. And what are your thoughts on this? I
would agree with my esteemed colleague, Sandra Johnson. So I would.
Wow. Brilliant. Well, I'm just looking at the time, we've now reached the end of the session. I wanted to thank you all, Pete, Sam, Professor Kerrigan, thank you so much for really, really interesting presentations and discussions. I know there's going to be a lot of follow on from this in terms of people who watch it on the YouTube channel as well. Amy, thank you very much for co-chairing, and to everyone who attended tonight. We hope you'll join us for the next education webinar on the 24th of August, and then the next journal club on the 30th of September, I believe. Anyway, thank you all. I hope you have a lovely evening and fantastic summer, and we'll see you soon. Good night.
Thank you.
Thank you.
Bye-bye.